So why are we doing this? Okay, I'm going to show you a short video of something that I have seen a lot in healthcare environment. And we are doing this quality improvement work as a way of stepping away from this way of working. So, I'm here to talk about spread, yeah, and how you spread quality improvement when you've got it working on a single unit. Now, I know that we're some way away from that point at the moment. You're still sort of doing PDSA cycles on single units. But there is a way to spread things, and there's definitely a way to not spread things. And one of the most important things that you have to be aware of, I always think, is the culture of the place that you're working in, because actually culture trumps everything. Okay. Some of you may have seen this slide before. 3 buildings. New Zealand High Commission in London, yeah. The Royal College of Physicians in Regent's Park in London, and North Shore Hospital, or what is now North Shore Hospital. So, the New Zealand High Commission, the Royal College of Physicians, were regularly voted as 2 of the ugliest carbuncles in London in the 1980s. People were outraged, yes. New Zealand had built this large structure near Trafalgar Square on the site of a bombed-out hotel in the 1960s as a means of showing New Zealand as a new country, new ideas, new developments. Architecturally, no connection with the area that it's positioned in. Regent's Park, 1830s, 1840s Nash terraces, with this sort of modernist building sort of plonked down there. And the architect that designed that Royal College of Physicians said that he didn't give people the buildings that they had dreamt of. He gave them the buildings that they never imagined that they would dream of. Okay, and that was Royal College of Physicians. Okay. About 1985, I graduated from medical school in Otago, and I got a job at North Shore Hospital as a house officer, and the surgeon took me to one side and he said to me, "This hospital is a big mistake." He said, "It is just a George Gare, who was the local MP, vanity project." And at that stage, I had the best emergency department job ever. That department shut at 10 o'clock at night, didn't open again until 8 AM the following morning. And all major stuff went over to Auckland Hospital. New Zealand High Commission, Royal College of Physicians, now both grade 2 listed buildings, yes. Loved by the people, yes. And George Gare, who died a couple of years ago, I saw in his obituary it said, "George Gare, man of vision," yes. Which just goes to show that things change. The environment that you work in change, culture changes. This is one of those diagrams which, if you're a senior manager, makes your heart sink. So these are all the things that you need to do in order to have a well-functioning hospital. But notice, culture sits at the top. Okay, so to have a positive organisational culture is probably the most important thing, and this work in QI is helping shape the culture of the organisation that you're working in. So, as I said, culture trumps everything. What is it? So it's quite an abstract concept, really. It's how we do things around here, and you'll have noticed that different DHBs do things differently. They have different attitudes. Okay, it comes from the very top of the organisation. So the very senior leaders in the organisation set the cultural tone. There is, I think, particularly in the NHS where I worked for a long time, a great love of the action plan. And I do see action plans tacked onto at least every sort of serious incident report, okay? You can't action plan your way out of a poor culture. It's something much more fundamental than that. You have to remember that no one goes to work to do a bad job. All the people working in the DHB want to do their best, okay? But there are things about the system that can set you up to fail. And you need to hang on to that when you're sort of having difficult conversations with the staff and the unit that you're working around PDSAs, because some people want to do them, some people will not want to do them. And you really have to keep that in mind. And you have to listen, yeah? You have to listen to what people are telling you. Okay, your staff have to have a voice. It's important. Listen to what they tell you. So what I'm going to talk to you about is a practical example from a unit I worked in East London for about 8 years as the Chief Medical Officer for the Trust. So the Trust is large. It was about 7,000 staff, mental health and community non-mental health, in East London, inner London, so rough, yeah, socioeconomically deprived. And as an experiment, when I took over as the Chief Medical Officer, we put a few staff through a training program run by the NHS Institute for Innovation and Improvement on quality improvement. So a few people got a go at learning some of the techniques that you've all had been learning. And they had to come up with a project to work on, quality improvement project. And they came to me, they had to pitch it to me, and they pitched it, and it was around reducing violence and aggression on wards. And my heart sank, yes, because I know how difficult it is to reduce violence and aggression. I've seen many people try and get nowhere with it in the ways that you are sort of working now on reducing seclusion and restraint, and a lot of people are saying, actually, no, it's not going to work. But however, in the spirit of QI, I said, fine. You have a go at it, okay? I'm not telling you how to reduce it. You come up with your own ideas and prove me wrong. And they did, okay? So the first ward that there is an acute adult inpatient ward. They came up with some very, very simple ideas about how to reduce violence and aggression on what was a really poorly designed ward in the first place. They had not much space. And when I came back to New Zealand, I went out to see the unit at North Shore. I thought, good heavens, yeah, all this space. Nonetheless, the team came up with some ideas using a methodology, PDSA cycle after PDSA cycle, and got a 50% reduction in the violence and aggression on the unit. Care of the elderly, so adult mental health, had some different ideas about how you might change it because their patient cohort is different. And they came up with ideas like reducing the amount of noise on the ward, yep, voluntary intentional rounding, which we've heard a bit about this morning, bringing a pet in because patients miss their pets, and so they had a variety of pets, and the one that people loved the most was a skunk, strangely, and no one knows why, but anyway they did. And they also managed to get a 63% reduction in violence on that unit. So that's great, isn't it? You've got one unit, but now how do you get everybody else to listen, take part, be interested? Because I tell you, it is natural human nature to say, well, it may have worked there, but it ain't going to work here. We are completely different, yes. And a Globe ward, there were four wards in a row, which were absolutely identical, yeah. And each of the three other wards said, oh, no, we're different, yeah. They're taking patients from the same part of London, the same sort of type of patient, exactly the same design of ward. Okay, it is our natural wish to think that we are somehow different and special. So, there are 7 things which you should not do if you want to spread something, and they're called the 7 deadly sins. Yes. So, sin number 1: don't bother testing, just do a large pilot. Yes. And some of you will no doubt have experienced that already. I don't see why we have to do small tests to change. Why don't we just do it and implement it as if it's something you just implement, and then it will be done. We'll give it to us. We'll give it to an operational manager to implement. Yes, or something like that. Okay. Give one person the responsibility to do it all. And you will no doubt in your DHBs have seen this for some of this work. There is one person on the ward who has responsibility for reducing seclusion, and 38 people on the ward who don't have responsibility for reducing seclusion, who are there to offer opinions and help. It's a team effort, okay, and spread really is a team effort. Rely solely on vigilance and hard work. This is not about working harder, yes, it's about working differently. Don't waste time adapting, just say, well, we did it this way, so you do it this, so you just do what we did and you'll be fine, okay? You have to win hearts and minds, you have to convince people, you have to get people to believe in what you say. Require the person and team who drove the initial improvements to be responsible for spread throughout the whole hospital. Yeah, okay. Well, you did it on this ward, now go and do it on the other 38 wards that are dotted around the place. Yes. So you have to have a spread team. You have to think about how you're going to do it. Check huge amounts of data just once every quarter. Well, we know we're not supposed to do that. I think everyone's got that message. And looking at the charts out there. Certain cases, and then expect huge improvements quickly. Yeah, it doesn't happen quickly. I have seen places doing 2 or 3 PDSAs a day. Okay, so those wards where they were doing the violence and aggression work, they were doing 2 to 3 PDSAs a day. Okay, so this is the IHI spread model, which I'm not going to go into detail. I'm not going to go into too much. But it's about leadership, it's about your social system, support, ideas, okay? It's complex, it's hard, it's tricky, it's why people don't do it, yes? It's why all health services struggle with implementing most suggested changes, even if there's 100% evidence, you know, that it will make a real difference. Because it's not how we work. So, this was our scale up and spread checklist that we used, okay? Basically, you can't spread until you're seeing sustained improvement in your unit. Not just improvement sort of yesterday or today, but over a month, 2 months, 3 months. So it's got to be embedded, it's got to be how your unit works normally, okay? People no longer see this as a project, it's how you work. You have to be able to tell people clearly what the components of the change package are. You can't say, oh, well, I don't know, we sort of did this and then, you know, Jack said, no, we should do this, so we added that in. You can't do that. It's not like that. It's got to be simple. You've got to be able to explain what you've actually done. You've got to be doing something differently rather than just changing what you're doing to do something better, okay? People have got to be able to understand it, and you've got to have some documentation. And if you can answer yes to all of those, then you're ready to think about how you might spread. So, having done it on 1 ward, they scaled it up and they did it on 4 wards. Okay. So what did they do? They made sure that their staff had been trained in the methodology in the first place. Okay. They introduced a safety culture bundle, and then they ran a series of learning sets. The 2, 3, 4 units all coming together to discuss what was working, what wasn't working, and how you might make a difference. Okay, and those learning sets carried on long after the improvement had happened. Okay, we're social beings. Most of us like talking to people, yes. So it's really, really important that you are sort of maintaining those sort of network social contacts.